Hey everyone, or for some of you, good morning. Welcome to another in a series of webinars put on by Priority Consult. We've had some great response to today's topic, and I immediately want to welcome Gina Delmont. Gina Delmont has been working with us for about a year now to put together a very effective spine program up just outside of Chicago, and we're excited to have her talk about her recent experience. You know, our experience with this process of putting together Priority Consult in different spine centers goes back about 10 years, and the process itself has evolved quite a bit over that period of time. And one of the things that we've really enjoyed doing, working with our customers, is trying to catalog just what does it take to make one of these programs really be successful. What we're going to talk about today are the phases that Gina went through to get to where they are, and talk a little bit, hopefully, about where they plan to go in the future. Before we get to Gina, though, just a little housekeeping. For those of you who are new to our webinar series, we do record these, and you can find them on the Priority Consult website. So I just wanted to make sure everyone had a chance to take a look at that after the webinar today. If you want to see what else we've put together, we've had topics from outcomes to marketing, to education, to nurse navigation, all experts in the field and folks that we feel have something to share, and we were so happy to have them on. This will likely be our last webinar of this year, but we're already starting to find folks starting out in January of next year. So Gina, thank you for joining us today. Just by way of introduction, Gina Delmont is a certified athletic trainer. She earned her executive certificate in healthcare delivery management from Cornell University and received a master's of public administration from Marist College. Gina was a member of the athletic training faculty at Northern Illinois University for 4 years before accepting the position of chief operating officer at Midwest Orthopaedic Institute, which we're going to call MOI pretty much for the rest of the day. She started that in 2005. Later on, she spent a couple of years in a similar capacity at the Orthopedic Clinic Association in Phoenix before returning to MOI as Business Development Coordinator in 2012. It was in 2012 that I began talking to Gina about her desire to develop a comprehensive spine program at MOI. Gina's actually been successful on a couple of fronts, and I, as I mentioned, hope she'll talk about both of these today. First, early on, I think one of the advantages that Gina was able to bring was the ability to craft a vision for the program that allowed her physicians to feel very comfortable buying into the concept. And secondly, she was very focused and quite involved throughout the implementation phase, which helped to ensure that things went pretty smoothly. Today we're going to hear directly from Gina on both of those phases, and as I mentioned, talk a little bit about what they have in store for the future. Finally, want to recognize that on for those of you who are not familiar with GoToMeeting, there's an opportunity to pose questions throughout the webinar. We will not be breaking in to the middle of the presentation to answer questions, but if there's some time at the end, Gina has been nice enough to stick around and answer questions if there's any submitted. So Gina, that's all about me talking. I'd like to get to you. Thank you very much for joining us today.
More than welcome, Michael. Hello out there today. The thing I really want to bring to you guys today is basically how I went about planning this and getting it implemented for a private practice. Started out and really had to think about the end in mind, and like Michael alluded to, had a vision for the program. Part of my vision for the program included the fact that if you're out in the private practice setting, I haven't found one really functional call center that does everything and follows every single iteration and rule for different orthopedic surgeons. So this enabled me to streamline that call center function and really provide our spine physicians with a really quality visit, which in turn ends up being a great service to the patients. So The first thing is I broke it down into 3 phases. And the 3 phases are a planning phase, implementation, and then reviewing what had been done and reflecting to see if it was still going in the same direction or we needed to make some changes there. In the first phase, in the planning phase, you know, we took about, I'm having a little difficulty here. Let's see. You got that, Michael?
Yeah,
okay.
We can move the slides if you're having some problem getting that done.
Yeah, can you do that for me?
Sure.
So in the first phase of planning, I took about 2 to 3 months to actually plan this. You know, I planned it with my CEO with the whole practice structure in mind. So so that was that. In the implementation phase, we did that within 1 to 2 months, and that's really driven by Basecamp, which is a web-based tool for project management. And then the review and reflect is something that's ongoing always. So phase 1 planning. First thing really that you need to do is you need to check your organizational structure. Best way to do that is find your organizational chart, and within that chart you will identify who really needs to buy in. And when it comes to buying in, there's 2 different ways that people can buy in. One obviously is a monetary way, and the other one is just they're buying into the process and they're going to play nicely in the sand with you. So with that being said, at MOI, the entities that needed to buy in were, number 1, the owners of the practice, the actual partners who own it. 2, the rest of the organization, so the whole practice, being employees, other providers, and anyone else within the organization. 3, the public being referring physicians. And 4, the actual competition, if and when you're going to include them in this process. So let's start out with planning and buy-in for the partner side. At MOI, there are 8 partners within the corporation. And here, when you're talking about getting them to buy in, I had to kind of show them the end in sight and show them what I estimated the outcomes to be as far as numbers within the program. And so they actually had monetary buy-in. That monetary buy-in really included an overhead cost or a personnel cost, because we had some extra staffing that needed to be appropriated to our MOI spine program. Of that being 2 care coordinators, an administrator, which is myself, so part of my salary is based for the spine program, and then the Priority Consult spine software itself. As far as the rest of the organization for MOI, we have approximately 25 providers with our mid-levels as well, and our organization is about 150 to 170 employees right now. So everybody from reception to call center and making sure that those calls actually get transferred to our spine center care coordinators, they all needed to buy in and understand the whole process. These people also, again, it's a different type of buy-in. It's not like they're dedicating and setting aside some monies for the program, but this was a complete change in procedures and actually how we dealt with patients and dealt with physician clinics. The third part of buying in was the public. So within that, I categorized that as the referring physicians, so ER physicians, primary care physicians in our area drive referrals. We have a large community of chiropractors, so I needed to get them on board and explain the program to them as well and show them how this was really a way to increase patient and customer satisfaction. Community members, some which are patients and some which are not. You know, we had two types of reactions that I kind of thought we might. In our reports to date, our highest percentage of patients report that they are self-referred. So we're not necessarily getting all of our referrals from the primary care physicians, but through, I'm hoping that's where our advertising dollars are helping us. So the first myth was, it's too good to be true. I submit all my information online. I give you all these test results. I send in all of my doctor's notes, and I basically get an assessment for free. I don't pay a dime for that. And then on the flip side, when they send in all of the information that they've already had from a provider that they've seen in the past, and one of our physicians says you need to get an EMG first, or we need to update this MRI, let's do that first. You know, we've had some people say, well, how can you know I should get an MRI before I've even seen the doctor? So we've seen it both ways, but for the most part I would have to say that that most people have really appreciated that streamlining. But again, it's a change in behavior, and it's a change in the way you do systems, and that's not always easy. The third population for planning within the buy-in was the public. We have several other VIPs, I would call them, and I'm sure, you know, we are not alone in having that population. Some of our VIPs are the athletic trainers within the schools. We're the team physicians for approximately 6 area schools, which in total we're talking about touching about 15,000 student-athletes' lives perhaps in healthcare. We also had our own physicians, family members, and friends. I'm sure some people, I hope you're laughing at this right now when you think about, you know, how certain people get a back door into your practice, and because they are a friend of your physician or a family member of a friend of your physician, they get in the door. Others are other physicians in our practice who are also our patients and their family members. So basically what I'm trying to say is there is no back door once you establish this program. Everybody needs to go through the process in the same manner. It's not to say you can't speed up the process to get people in faster that perhaps may be taking a more conservative approach, but the first step of the process is to do the medical intake and not just be added onto a schedule. So, fourth, with planning and buying in, is the competition. What I mean by the competition is, you know, there is a place within every spine program using Priority Consult to include other providers. And some might think it's competition. The way I chose to look at it is we can't do everything the best in the area. So I identified who our physicians were comfortable with as far as rehab providers, as far as primary care physicians, because a lot of our patients report they don't even have a primary care physician, neurologist in town. I come from, MOI has orthopedic spine surgeon versus a neurosurgeon, so we needed to find and hopefully work well with a local neurosurgeon. The chiropractors and certain imaging centers. We're trying to draw from an area that is a radius of about 200 miles. So, you know, we can't do everything within our own system, so we have to reach out and get partners that way. The second phase is implementation. And I basically broke that down into 9 steps. the first step is branding your program. You have to make a new brand. It's got to stand out from the complete package, which is the actual, in our case, Midwest Orthopaedic Institute. And the second one's delineation of roles. Then we have meetings, process planning, training. We had test patients for about a week. We picked our go-live date, and then we had to really manage and agree upon our performance measures, and then wait for the results to come in. So branding. Again, you can see on the slide in the lower left corner is our Midwest Orthopaedic Institute overall practice logo. The squares next to the MOI letters represent what we always thought of in our vision planning back in, I would say, 2000, would be the centers of excellence within that orthopedic program. So basically, you know, upper extremity, lower extremity, sports medicine, pediatrics, and spine. So this was the first actual time that we went ahead and started branding our centers of excellence alone. And so spine did that, and we kind of like this logo. To the right then is our MOI spine logo, and underneath it, it says a center of excellence. Since this process, we have gone ahead and branded just about every single one of our centers. So, and again, that was a decision and a vision that was seen 10 years prior. Also in the implementation phase under branding is getting a separate website. I have to give kudos to my buddy Jane in Salem for their spine program, because she allowed me to really pick apart their website, and I love their website. We added our own flair a little bit, but it looks very similar. So there's a picture of our front page of our website. Also within branding, you have to get your collateral materials together so that when you go out to educate the public, you're able to obviously leave them with something that they can refer back to. In this case, we chose to have a frequently asked questions. We have two versions, one for referring physicians and then one for patients, so that what they might ask and what they might receive the information back. It's pretty typical in our practice to have physician bio cards, which are almost like a little menu card type. It's a heavier stock. It has the physician's picture and then a little bio on the docs. We had all our 3 spine docs, 2 of which are physical medicine and rehabilitation physicians, and then 1 orthopedic spine surgeon. We had them redone after we went through this branding phase, so that they could talk in their bio card and refer to our spine center about why they want to be a part of it and what they like about it and why they think it's very patient-centered. And then also we have little fun little spine keychains that are always a talking piece. So those are our collateral materials right now. Second part of the implementation phase is, in my opinion, incredibly important. It's the delineation of roles. So basically, I took a list of our personnel, and which included a medical director. So one of the 3 spine docs had to take that role on. At the time that we first implemented, we had 1 nurse navigator and 1 care coordinator. Since then, during our reviewing and reflecting, it's best for our program to have 2 care coordinators and not have a nurse navigator. But so I had the roles and set the boundaries for those. Also, the administrator myself, what am I responsible for and accountable for? What role do I play? And how long do I play that role, actually? And then the other part of the personnel are the doctor's assistants. In our case, we have all certified athletic trainers working as physician extenders with our physicians. And so at what point do they step in and do things, and at what point Are they part of the MOI's program, or are they part of the overall clinic? So within here, it's really important to set boundaries. You know, again, giving everybody their own role and letting everybody else know what those roles are so that people aren't stepping on toes and it's really not chaotic. This is also the time when you can set your culture for your program. Very important to me. I have a high interest in corporate culture and corporate organization. And I really wanted to set this culture to be one that people weren't afraid to ask questions. People could walk over in the clinics and talk to the docs. The docs could walk over and talk to the care coordinators. The doctor's assistants would, you know, feel comfortable IMing everybody, asking questions, so that, you know, there was really no hierarchy when it came to making this team work. And so, you know, all these people needed to function as a team and function in a very healthy way. And I would have to say that's maybe one of the most things that I'm most proud of in our program. So after that, then we had some process planning going on. And I should have really flipped this to be the first thing in the process planning is Priority Consult's recipe, which Priority Consult uses Basecamp. Now, I had mentioned Basecamp earlier. Basecamp's a web-based project management tool. They have it so that you have steps to accomplish, and they're in small enough bits that it doesn't seem overwhelming. The best thing about this is once you complete all of these tasks, in the end outcome is that all of it comes together and populates your software portion. And what you don't realize is it also populates your policies and procedures manual. So it's a great way to organize and actually build the guts, so to speak, of the spine program. So the meetings included just the 3 docs and myself. We met twice a week for the first 2 months. And basically everything on Basecamp we would discuss, hash out in those meetings, and then I would go on and I would add to Basecamp. And but it was good to have the dialogue. We learned a lot about each other. We learned how to work together. So that was very important. Our care coordinators, I met just about every day with them for a month. I wanted to get into a routine with them that we would meet, we would plan, we would ask questions, we would get our work done so that there weren't the constant interruptions during the day or, you know, asking the wrong people certain questions. So we kind of met up every day for about a month. We went through things. Also, at that point is when I went through with them the details that the physicians hammered out as far as who they wanted to refer certain people to. And then I brought them all together, and we had an MOI spine team meetings, several lunches, and that was all the docs, the care coordinators, myself, the ATCs with the doctors in clinic, and the receptionist that was up in our MOI spine area in the building. I thought it was very important to include her as part of this team and make her feel like she is the quarterback from that side, because she will get asked a lot of the questions, and also became a instrumental person for our in-house referrals. Next part of process planning is, you know, I have to tell you, it's probably the one that I do every day, and I don't think that it will ever end. And I'm okay with that because we've gotten good results. That's education. Again, educating the MOI spine team, all those people that I mentioned previously, to the policies and procedures of how we're going to run our practice. And again, we did that weekly, daily, depending on which groups it was, and then we brought everybody together. The rest of MOI. So the rest of our 25-plus providers, we have a monthly provider meeting that run, at which point I discuss some development issues. And so during that meeting is when I would really talk with those providers about what our process was, what it would look like, what the outcomes that I'm expecting are, and for them what to expect. Then with the employees, remember it's about 150 plus, I held separate meetings with each group of employees, group by job function. So there's a clinical group of employees that all work with the different physicians. Those are the people on the front lines that when the doc comes out of a room and says, hey, Brenda, can you make sure that this person gets referred to the spine center? That person has to act then on our behalf, on the spine center's behalf, as a liaison to explain what's going to happen next, to start all the triggers that take place for that referral to happen. So very important for me to get their buy-in, to educate them, to show them what it would look like within our EMR system, to send that task, what information we needed, why we needed it, so that they could perform successfully for us. Then I met with reception and call center. Those are the people who actually are the ones who physically send the referral via our EMR system. So every time an employee changes, I'm sure you can imagine, it's going back to stage one and really getting their buy-in, explaining the process, explaining what we've learned up to this point and what seems to work best for our employees. Another area is medical records. That's what MR stands for. That is so that we have a dedicated fax number for the spine center, so that when we're getting other records in, they can be directed towards that fax number. However, MOI has been here for a very long time, and our fax number, our general fax number, is out there. So we still have faxes that, even though we're putting out our spine fax number, it gets faxed to the normal MOI medical records number. And so I need to get her on board so that she knows exactly that, we're waiting on that. It's literally a stat fax in our eyes, so she doesn't put that at the bottom of her pile and scans that right into our EMR and sends a task to our care coordinator. So lots of education, but it does pay off, I will tell you that. The next part of implementation would be the training. And this is the training done with the Priority Consult Spine software. And the most, wonderful thing about this is it's all done via the web with GoToMeetings. And we had some care coordinator training, we had physician training, we had nurse navigator training. And I sat in on all the training sessions. I come from a place of my philosophy of management is I need to know how to do it so that I can manage it. So I sat in on all those training sessions so that, the employees knew I knew what they were doing and could help them at any moment. Then after the training took place, which, by the way, I have to give a shout out here. The training is simple, doesn't take a lot of time. I'm talking 15 minutes for physicians and, maybe a total of an hour or an hour and a half for the care coordinators. So it's a very simple system, very, it's common sense. So it fits a practice easily. Next part of implementation would be test patients. So here we created test patients for a full week, and we created them in Priority Consult and took them through the whole process, navigating them from person to person, having the physicians do kind of fake reviews. I also took it a step farther and literally role-played and had a patient come out of the office, had one of my PAs tell one of the doctor's assistants to send this person to the spine center, broke that down even more and had them send to the spine center, then had them send to a particular physician within the spine center. I walked up to the pod receptionist and I sat with her when she filled out the actual the referral through the EMR, watched her hit the task, walked back over to the care coordinators, watched how fast the task came through, and then took them through their process. So we did that for a week. So it paid off because when go live date came up, which we picked as March 12, 2013, we were eager and ready. We couldn't have had, I mean, we had patients right away, but I can tell you that we could have taken on probably about 100 patients right away. We were just that ready for it. So that's a good thing. As far as our performance measures, you know, one of the greatest things for me and one of the reasons why I really wanted Priority Consult as our software program were the rich reports that we get monthly from them. You know, I'm also, my philosophy on management is to manage by data and not by emotions. So I get data sent to me monthly, which really drives our next step. Within these monthly reports, we've picked our top 10 because there are several reports, but we picked the top 10 that we wanted to manage the program by. So our top 10 include a monthly count, how many new patients presented to the spine center. And for the most part, we see the same types of trends and lulls with patient appointments within spine as we do with our overall orthopedic practice. So I'm going to go ahead and say that that's a good thing. Plus, we've been really happy with our monthly counts. Another important thing is, how did you hear of us? I want to find out exactly what's working out in the public, and each public is going to be different than another public. Our TV ads work really well for us in our outlying areas, the ones that are farthest in our radius. Within the ones that are closest to us, and within, I would say, a 20 to 30 mile radius, the best way we have been reaching these patients is to do community wellness talks through our local hospital. So we're able to track those patients to find out who was at that wellness talk and what exactly within that wellness talk is what made them present to our spine center. So very important, because it's really hard to it's hard to measure marketing. People say that you can't do it, but the wonderful thing about this is I've been able to do it with MOI Spine, so that's a good thing. Next part is patient home city report. Back on our website, we have a little tool on our left-hand side, which is basically Google Maps, and we put a pin in for every city that we get a patient from, because one of our main goals and our vision for this was to take this program and, like I said, do anywhere from 200-mile radius. And so we grade ourselves by how many new cities we gain, referrals or patients, monthly. So that's important for us. Our payer mix report, you know, I'd be lying if I said I don't get evaluated on the money that the spine center brings in, but this is really interesting. Our top 3 payer reports have been Blue Cross Blue Shield, Medicare, and our version of Medicaid. So watching those 3 exchange places and then putting together that report with how did you hear of us, along with patient home city report, really gives me an idea of how to target patients in a particular payer mix if that's what I wanted to do. So really interesting. Facilities selected by nurse navigator, or in our case, care coordinators. I'll tell you why that's really important to me is because when I'm going out into the public and I'm recruiting what used to be our direct competition, you know, there's an agreement there that says, you know, you scratch my back and I'll scratch yours. You refer patients in, and I'll make sure that you get your patient back if they came from, let's say, a rehab clinic or a neurologist or whomever. So within that neurologist's office, you know, they also offer the ancillaries of EMG reports. So if I get a patient from one of our local neurologists, I need to be cognizant of the fact that that neurologist is expecting that patient to come back to him or her to get their EMG and for follow-up care. Very important, because that's how you build relations and trust, and you make that relationship work. So, you know, I'm able to go back to these places that we have joined forces in a partnership with and report to them that they sent us 5 patients that month, and they were referred 5 patients back for an EMG or 5 patients back for rehab or whatever it is that we have fulfilled our unwritten agreement with them for. More of the top 10 reports would be appointment specialist report. Again, this tells me the type of patient that's presenting to the spine center and what perhaps we need as far as ancillaries. It also tells me, gives me an idea of the breakdown with our own 3 spine physicians and how many each physician is receiving via referral, so that if for some reason, which we don't have, you know, if one person's doing all the work and the other 2 spine docs are kind of not. Let's see, the next one is the referral report. Again, is the administrator and also the business development coordinator. I want to know who's referring into our spine center. If I see 1 month, one primary care office referred 20, and then the next month that same referrer only referred 5, you know, I can make an educated call. I can stop by and say, you know, just wanted to check in and find out if everything's going well on your end. If you needed anything changed or tweaked to make it work for you, let me know. So it opens up conversation for those referrers. Same with our PCP report. Again, when I'm going out and trying to recruit some business from the PCPs, I'm able to tell them, and you know, this is a true story. I actually did this with 3 of our PCPs. I'm able to let them know that, you know, 40% of our patients report not having a primary care physician, and that we too want to have their support, so that when we have somebody who presents, let's just take it to the nth degree, and that person needs surgery, well, that patient also needs a primary care physician to do an H&P on and a medical clearance on. So we're able to give business back to them as well. Our trending lag report, that tells me how fast patients are moving through the system, and really if there's a bottleneck anywhere. And also we have, you know, we have goals and objectives for our own program as far as how long we have a tolerance of people being in the system, and from the time they call in to the time intake is done to the time their first review, ongoing, until the time they actually see present into the office and see a physician. So I'm able to evaluate us based on what our overall goals are versus what that report shows me. The lag report by appointment urgency, luckily we have not had to have that. However, what that tells me is, you know, in a case of like cauda equina syndrome where it's a 911 and we need to react fast, so that basically all of the triggers within the medical intake are flagged, and you know, that person's actually getting seen, it's getting reported, it's not just, you know, kind of like a mill of patients going through. I mean, we are paying attention to those urgent appointments. So next phase 3, review and reflect. Well, I review and I reflect all of the time, even on my drive home or at night, which I would not, I would tell you not to do. But anyway, quality of performance improvement. If I knew then what I know now, what would I do differently? Well, I can tell you within the planning phase, I would become more familiar with Priority Consult. What I mean by that is this is a rich program. However, I think it's a program that is only going to work to your benefit for as much as you get yourself engaged with it. And you know, I don't think that I did it justice when I started, simply because I didn't know what it had to offer. And so when I say that, I'm talking about the documents within their Basecamp recipe. So when you're online in Basecamp, that web management tool, all of those documents, and knowing that once you fill those out, that's what's going to populate your software program, which is only going to make your process and daily operations run smoother. I think it's important to know that. And if my physicians had done that, I think they would have done their homework even a little bit more. They were very involved, so I can't complain about that, but I don't think I knew enough. Also, the reports available. The interpretation of the reports and where the data gets pulled from within the software to populate those reports, I think that's really important, and I wish I would have known more about that. The reason I say that is because it took us probably 2.5 months before both of my care coordinators understood, because I didn't understand where those numbers were being pulled from. So very important for them to know that ahead of time so that they are actually you know, checking the right boxes so that the reports are as accurate as possible. Again, you know, my two care coordinators, I can't express how much they make the program run, and they do a great job. I'm definitely a believer in people being part of the system. I think you can build a franchise operation, but I also think that you need the people who have the buy-in and the ownership of that, and those two definitely have that. So they took it actually quite personally when the reports came back and they thought they were low. So they made it their business to understand then where they were coming from. But again, this all could have been prevented had I given it enough time to know that. Also within the planning phase, wait to involve the spine-centered physicians. I really involved them in step 1. And when I did that, I almost undermined my own self in that process, meaning, you know, I had them challenge me a little bit, and I wasn't equipped. And, you know, that's on me. But I think they should have buy-in from the beginning, so, you know, they know how they want their website to look. But really establishing the boundaries a little bit more, I think, would have been better. It would have just saved a lot of learning experience, I guess. The second thing within the planning phase would be, you know, I talked to several people who had used this program before about what is it that the nurse navigator does that a care coordinator cannot do. And I think in a hospital setting, I think it's very important to have a nurse navigator. I think nurses are comfortable in that position. I think they're used to that. I didn't think so in a private practice, and especially in orthopedics. But I didn't listen to my gut, and I hired a nurse navigator, and I don't think that person was utilized to her capability. It's an expensive FTE. And I would expect that person would use more nursing knowledge than would use technology perhaps, or just knowing the ins and outs of an organization. So I would have listened to myself a little bit more and gone with 2 care coordinators at first, but it really didn't put us behind. But like I said, my 2 care coordinators, they know the ins and outs of the practice, and they are the ones that I have to give kudos to making this program and the numbers look so impressive to me at the end of the month, because they're doing it day in and day out. That's really it. I am definitely open for questions. I hope this has helped everybody, and please don't hesitate to send me any questions you might have in the future.
Gina, thank you so much for what I think was a very comprehensive look at what people experience, and it is so critical, as you said, throughout, to really have an idea of how you want to manage this process in those first couple of months in particular, because that's what sets your foundation for all the success you hope to receive in the future. I'm going to ask those who have attended to go ahead. If you have any questions, go ahead and feel free to populate those in the box. I've got some questions here, Gina, if you don't mind taking them.
Sure, Michael.
All right, very good. Let me see if I can, actually I've got 3 or 4. I just got to open this up here. So the first question is back to the idea of buy-in, and you gave a number of different audiences that you had to go speak to about really the new method. So the question specifically is, which of those parties gave you the greatest objection to the concepts that you were trying to promote, and what messages were most effective, if they were effective, to resolve their concerns?
That's a great question. It pops up 2 different things, and for 2 different reasons. So I would say I did have a lot of objection from the rest of our organization, so the rest of our providers and our employees. And honestly, that's because of the change in the process, I believe, and people just get, comfortable in the old ways of doing things. They walk over, they call one of our docs on their cell phone and say, hey, I want you to see this patient, and they expect it to happen right away. And how I solve that is showing them that they're being seen in the same amount or less time, and the patients are actually happier. And how I've done that is I've included them in certain tasks on our EMR system that pop up that let them know their patient, has been reviewed, is being seen, has been sent for an MRI, etc. So I think that's helped. I've also showed them, I meet with the partners and the rest of the providers and show them some of our monthly reports. And then the next part would be the public. The referring physicians, I'm on my 2nd go-round, I believe, right now, with our referring physicians kind of having questions. And I think that's because they're used to referring to one particular physician versus referring to the MOI Spine Center and letting our physicians determine which provider is best for that patient. And, in a small community, it becomes where, our referring physicians think that our spine surgeon's not seeing the patient that they refer to him. Instead of understanding that the spine surgeon isn't the most appropriate physician for that patient. The spine surgeon is exactly that. In our case, he's a surgeon. He doesn't know how to treat the conservative management portion. Patients do much better when referred to our physical medicine and rehab physicians to begin their treatment in a conservative way than when they're sent to our spine surgeon. So that's my biggest battle right now.
Excellent. Thank you. Patrick asks, we got a couple more, keep adding on, so we'll keep going as long as you're willing to go. In your performance measures, can you compare functional outcomes with other centers? And then they go on to talk about length of stay, cost, infection rate, readmission. I know you're doing some of those. I'll let you speak to that, and then I might throw in a couple 2 cents as well.
Okay. I'm assuming the question meant, am I able to kind of grade our MOI spine outcomes versus perhaps another center of excellence outcome?
Yes, yes.
Okay. Unfortunately, I can't right now. If I do, it would be anecdotal. I can only speak to the data for spine because we don't have that model with our other centers of excellence, which brings up a great point. You know, I would love to develop that model for the rest of orthopedics because now our physicians in the other centers are actually quite envious of the priority consult method we use with the software because it really makes their job much easier and our outcomes are so great. Another way that I do it for the functional outcomes within the patients that have surgery, our hospital utilizes the Marshall Steele program for spine. And so some of our outcomes are done via their program versus ours with conservative measures within priority consult. So I now get the reports from the hospital and I kind of grade them against our conservative management to give me kind of a whole picture of the whole spine program, if you will.
Excellent. And if the question were also related to other spine centers around the country, there are elements of that through Priority Consult, which, Gina, I know you've been part of that more recently. Maybe not at the very beginning, but certainly there's a desire on the part of a lot of spine centers to get a sense of where they stand against other programs around the country on things like oswestry, neck disability improvement, length of stay, et cetera. And that's a whole other segment of reporting that the software can provide. Not every center actually pursues that angle, but we've seen a steady increase in participation over the last 3 years in particular. Got a couple more for you, Gina. We're teaming up with the hospital to set up our program. Should we hire the intake specialist and the care coordinator position to house in our office? So you did this without a hospital. If that wasn't clear from the very beginning, I think it's worth noting. You know, most of the folks who go through this process actually will see the hospital finance all of it. You went on your own, and maybe on another webinar we'll do a whole talk about the difference between physician practice versus hospital. But from your perspective, with the limited information in the question at this point, but do you have some perspective on having that front-end staff in the hospital versus the practice? Why did you choose to do the practice?
Well, we chose to do the practice because the hospital elected not to purchase the conservative management program piece within the Marshall Steele spine program. And, you know, I'm glad we did because the majority of patients, you know, more than 90% of patients who present with back or neck pain are not surgical candidates. So that whole population would not be served by the surgery piece. That being said, the fact that we're an outpatient private practice, to survive in the world of healthcare now, you have to have ancillaries to boost your bottom line. And if we have the intake coordinators within our own office, we're able to, I should say, better control those ancillary referrals and able to fill them up. So I'm a fan of having them in-house because it just automatically kind of fills up our ancillaries, and it helps us, obviously, with communication internally.
Excellent. Thank you. Very, very useful perspective from the practice side. I'm sure our hospital administrators listening are listening intently to that as well.
Yes,
two questions from that are kind of the same, both from Katie and Karen. Can you talk a little bit more about your RN? About your care coordinators? I know that they're not RN. Can you talk about? You already mentioned it a little bit, but talk about their qualifications, their experience levels, and why you are comfortable working with them. Certainly, I'm sure that the fact that they're in the practice with you and next to the doctors has some impact on that. But can you speak a little bit more about kind of who's working in that role?
Absolutely. Actually, our care coordinators are staffed right outside my office. We now call it the East Wing because we are segregated, and we like it, by the way. And the two care coordinators, I'll tell you, one has prior spine experience in a different state, and she is a certified medical assistant, so she has some, baseline level of medical knowledge, but her experience of, I think, 10 years working with a spine surgeon really puts her ahead of the curve. Both are very customer service oriented, and so are great on the phone with patients. My other care coordinator, who is my lead care coordinator, she was a person that I hired, I think 7 years ago, to when I started the MRI ancillaries within the practice. And, she's about to finish her degree in healthcare administration, her bachelor's, and she's just a go-getter, and she's just, she's smart. She catches on. She has a business mind. She soaks everything in, so she's a sponge. She's worked closely enough in her MRI experience with all of these physicians and the assistants to know what they're looking for, what's important, what's not. She made it her business to know that in doing the MRI portion, so she's very good at pre-certing, and I really think it is about her being involved in our practice. I also think with her knowledge, she could go to another practice and do the same thing, but I think it's because she's got such a close relationship with our physicians.
Mm-hmm. Well, this next question is going to be from Mike in Cincinnati, which is me. To kind of extend on that, is there anything that you would kind of document or have documented or in the training that said, look, you're not a nurse, so we draw the line at this? In other words, understanding that a lot of, and I agree, there's a lot of things that really, if you've got the right kind of person with enough experience, they're going to do a great job. But are there some elements where you say certain symptoms that are presented or other types of education that you say, look, leave it to the ATCs or leave it to the doctors to share this type of information?
Absolutely, actually, and that's a good qualifying statement. We don't have it written down, and again, I mean, these two people are right outside my office, so as much as I need things to be absolutely quiet for me to concentrate, I hear these two on the phone all the time, and I'm really tuned into them, so I'm able to evaluate them on many levels daily. I believe it's an understanding of knowing what they know, what they're capable of saying to the patients, and what they're not. Once a patient presents in the clinic and is undergoing treatment on a, with one of our physicians in person versus an online review, that's when we kind of swap hands with discussing the conditions and all of that with the patient. That's when the APCs take over, and they describe the treatments, and they talk to the patients about the medications and refills and everything. Our care coordinators, they document everything within Priority Consult, but at that point, they become more of a call center, so that if there's a reschedule of an appointment or somebody doesn't show up or they need to be referred on to somebody else, it's the care coordinator that actually does that. It's not that they're talking about their treatment at that point that they've gotten from the physician.
Excellent. Gina, thank you so much for spending an hour with us today. I'm sure there will be people who would like to contact you directly, and I've got moispine.com, which I think is really one of the better websites I've seen. There's great content on here, great educational material. This has been a very useful hour, I think, for a lot of our audience today. This is, as I mentioned, the final webinar of the year, but if you didn't hear the whole thing or you want to share this with a colleague, go back to PriorityConsult.com. We're going to try to have this up by tomorrow, but certainly we'll be sending out a link to everyone who attended in case you want. I know one question we didn't get to, but I'll address right now. Is this presentation going to be available to the audience? The video or the webinar itself will be available as a video download. And as far as PowerPoint slides and so on, that's a common question. I will let Gina kind of address that. You might want to contact her directly for some of those questions. The very good content today, Gina. Thank you very much for your time. And for everyone, thank you for attending, and we'll see you again next time.
Great.